Welcome to Speaking of Midwives, the official podcast of the Journal of Midwifery and Women's Health, where we bring the pages of the journal to life. I'm your host, Melissa Avery. Each episode, we go deep into the evidence, spotlighting the researchers, the breakthroughs, and the midwives leading the science that is transforming reproductive health care. Greetings and welcome to Speaking of Midwives with the Journal of Midwifery and Women's Health. Today we are speaking with Dr. Nikia Grayson, midwife, Chief Clinical Officer, Choices Center for Reproductive Health, and Associate Professor, School of Nursing, and co-director of the Nurse Midwifery Program at the University of California, San Francisco. We are talking about her article, The Choices Black Midwifery Fellowship, an innovative model for training midwives and reproductive justice, and community-centered care. Welcome, Nikia.
Thanks for having me, Melissa.
Would you begin our discussion today by just sharing a little bit about your background in midwifery and maybe how you got there, because it's quite interesting.
Yeah, my path to midwifery was not especially linear. So, I have a background in public health and medical anthropology. And really, actually, I became a family nurse practitioner before I became a nurse midwife. But the thread runs through all of our work of always being a reproductive healthcare provider, right? Being reproductive healthcare focused, community care focused, and really trying to understand how larger systems shape people's health and their experiences of care. So, I came to midwifery because I saw it as something much bigger than attending birth. I saw the possibility of relationship-based care, bodily autonomy, continuity, and really caring for people across their reproductive lifespan. So, like you said today, I'm the Chief Clinical Officer at Choices Center for Reproductive Health in Memphis, Tennessee, and Carbondale, Illinois. And I'm also an associate professor in the nurse midwifery program at UCSF. But much of my work has focused on expanding access to full spectrum reproductive health care and really growing the Black midwifery workforce, right? Especially particularly in the South. And so at the center of all of it, I think I'm really a midwife and a community builder. So I'm interested not only in how we train more midwives, but in the kind of systems we need to build so that they can thrive. And so communities can truly experience care differently.
Right. Absolutely. Well, so you mentioned your position at Choices, and it changed since we first got acquainted. And you actually, prior to the article we're really talking about today, you published a piece where you talked about the care model at Choices. So I'm going to ask you just to share with our listeners a little bit about that so they understand kind of where you're coming from in terms of the clinical part of your work and the team you work with before we talk about the fellowship.
Yeah. So, Choices is an independent nonprofit reproductive health care organization that has been serving Memphis and the community for over 50 years. It was founded in 1974 as a feminist health center, providing abortion. And really over time, it evolved into a much broader model of comprehensive reproductive health care. And so today our work spans sexual and reproductive health, contraception, prenatal care, midwifery care, birth, postpartum services, gender affirming care, and abortion care through our Illinois location. I think one of the things that makes Choices unique is that we have intentionally resisted the fragmentation that is common in reproductive health care. We don't believe people live lives that fit into separate boxes, one place for contraception, another place for pregnancy, another place for birth, another place for abortion. People move across their reproductive lifespan, and we wanted to build a model that could move with them, right? So we do serve a predominantly Black and underserved population, and most of our patients are on Medicaid. So when we opened our freestanding birth center we were not simply, adding another service. We were asking our community what they needed and what it would mean uh, to make community-based midwifery genuinely accessible to families who had historically been excluded from it, right? And so importantly, we have intentionally built a Black midwifery workforce. And really that has been the foundation for our fellowship. And, especially, I'm sure you're familiar with the history of Black midwifery, especially in the South, and how Black midwives really have been pushed into extinction through demonization and policies and politics that were unfavorable to them. And so for us, it was really important to see a restoration and a reclamation of that.
And you've done that in a really interesting way. Can you just say a little bit more about who works at Choices? Who are they?
Yeah,
Who are they?
when I came to Choices, it was physicians. Yeah, and so we have been intentional about the leadership of midwives and midwifery, right? And that midwives are comprehensive reproductive healthcare providers and primary care providers, and that we do more than catch babies. So we have amazing team of 5 Black midwives that I recruited or uh, taught or was their preceptor or something along the
Got them
way.
in there.
You got them in there, right? And yeah, so we have Alexis Dunamore, who's also a professor at NYU and past ACNM, immediate past ACNM vice president, Talita Asagara, who came to us from UCSF as a new midwife. Kiera Norman, she is presently one of our midwives. She was one of our fellows, and she's from Memphis. She was one of my interns at one time. Uh, Akaniana Ruffin, she's a brand new midwife. She's our fellow right now. And then myself. And then in our Carbondale clinic, actually 6 midwives, we have Carrie Stewart, who
Oh,
is our director of family health and midwifery in Carbondale. So she is working on starting the midwifery practice there. Right now, she does family planning, Title X, and abortion care and gender affirming care in that clinic. So, and she will be starting the prenatal care services and birth services in that clinic very soon. So, for us, it's important to create these spaces and create comprehensive providers, but also, like I said, to highlight the work of Black midwives and what we can do and what we do mean to our communities.
mhm. So, one more thing I'm going to ask you just to address in case the listeners are believing that they heard Memphis and Carbondale, Illinois. So, would you just say a sentence or two about how that Carbondale clinic got started
Yeah,
and when? Because that was a big
yeah,
deal.
yeah. It was a big deal, and it was a big pivot for us. So our Memphis clinic, like I said, has been in the community since 1974 and always provided abortion care. And we knew that when the Dobbs case was taken up in late 2021, that we would lose abortion access in the South. Many funders and others in the community was like, "Oh, you don't know that." We were like, "Have you all been paying attention?" So for us, we had just opened our new clinic here in Memphis and our new birth center. And it was a huge pivot. We knew that abortion access was necessary for our community. So we made the decision to open a second clinic. And we knew that all the southern states would lose access. So the one state that was closest to us was Illinois. And Illinois has protections around reproductive freedom. So uh, we went to Carbondale and did some landscape analysis there and met with community members and told them what our idea was and to determine what they wanted to see in the clinic as well. We didn't just want to come there and didn't we wanted to be of value to the to that
Yeah,
community.
right.
And so we opened that clinic in October of 2022, a few months after the Dobbs decision. And so it's about 3.5 hours from our Memphis clinic. And it's been there now for 4 years, almost 5 years.
That is really amazing. Still to me today, it's amazing. How has the um, well, let's see what I want to say. The growth. Are people coming? Is it expanding?
People are definitely coming. Yeah, and the majority of the people that we see in that clinic are coming from the southern states, right? So, yeah, I would say probably about 97% of the people that we see are from not from Illinois.
Mm-hmm.
So they're from the
Yeah,
southern states.
yeah,
And so it's unfortunate people have to travel to get the care that they need, but it is important to us that people get the care they not only need, but that they deserve. So we will continue to,
yeah,
provide those
yeah.
services. Yeah.
Wow. Well, thank you for providing what people are asking for and for sharing a little bit more with the people listening. So then from that, from the clinic and your expansion, would you talk a little bit more about just what led you to your interest in developing the fellowship? Now we're kind
Yeah.
of going from care to education.
Yeah. Yeah. Well, the fellowship grew out of both urgency and frustration, right? Um, um, we had talked about for many years the lack of diversity in midwifery. And, and often the response is we need to recruit more Black students. While that is true, recruitment alone is not a workforce strategy, right? And so, Black student encounter uh, that we had talked to many Black students about the encounters with um, in their midwifery programs, and they really talked about encountering barriers, getting into programs and paying for programs, but also securing clinical placements and finding mentors and navigating environments where they may be one of either only or very few Black learners. And, then we celebrate when they graduate and sometimes send them into practices with very little, structured support. And, for me, I kept thinking about what happens after graduation, what happens, um, to them when they go into these new spaces, and who helps a newly graduated midwife move from knowing the material to trusting their clinical judgment, and where do they learn community birth if most of us are really trained in highly medicalized hospital systems, and where do they learn about abortion, where do they learn about policy and advocacy and leadership, and how to build relationships with communities. And where do they learn those things in a safe space? And so the fellowship grew from, our belief that we needed to create that bridge. And specifically, we wanted to create it for Black midwives and a Black-led community-based reproductive health organization, right? And it really also, like I said, the frustration for me was what I didn't get, right? When I, graduated and came to Choices, one, there were no job opportunities available in Memphis, and we don't have a big midwifery community here. At the time, it was only maybe 3 nurse midwives in the community, and then myself.
Mm-hmm.
And I was the only one that was doing out of hospital community based care. And so for me, it was fellowship was about what I didn't have when I graduated, and recognizing that we cannot recruit, Black midwives into profession and then leave their survival and success to chance, right? So this was really important.
Yeah, that's a great way to put it. Thanks for that. So, in the article about the fellowship, you talk about two underlying principles: Black feminist thought and reproductive justice. So, would you explain? I mean, people can read more, but would you just
Hmm.
give a little bit of information about those two important principles to our listeners?
Yeah, yeah. Black feminist thought, ask us to take seriously the knowledge produced from lived experiences, particularly those experiences of Black women and other people whose knowledge has historically been marginalized, right? It gives fellows a way to examine how race, gender, class, power, how these things operate simultaneously, not only in society, but inside, healthcare institutions as well. Um, and reproductive justice, really then pushes us beyond a narrow idea of individual choice. It asks whether people actually have the social, political, and economic conditions necessary to make meaningful decisions about their reproductive lives, which are, like, do they have what they need to make decisions about the right to have children and not have children, to raise their families in safe and sustainable communities, right? And then fundamentally, that changes how we train a midwife. Okay. For me, those principles uh, just embodied everything, all the work that I do. And because I can teach someone how to interpret, like a fetal, tracing or something like that, or how to manage labor. But if we don't understand our patients, um, why our patients live in the environments they live in, or why they live in maternity care deserts, why a hospital closes obstetric unit, why Medicaid uh, policies really do shape access, and why Black patients are not believed, or why abortion restrictions, affect the entire reproductive health ecosystem, then we have not fully prepared them to care for our communities.
So
So,
I'm going to come
yeah,
back and thank you. I'm going to come back and ask you a little bit about the nitty gritty details of the fellowship. But first, I want to go from these two principles to the 5 pillars you identified: full scope reproductive health services that you've been talking
yeah,
about.
yeah,
Um, again, Black feminist thought,
yeah,
leadership and mentorship, neonatal and postnatal care. And interesting, you pull that piece out specifically. So
yeah, yeah.
yeah, and then community and patient-centered care, as you've also been talking about. So those,
Right. Yeah. Yeah, I think the 5 pillars really emerge from asking what kind of midwife are we trying to develop, and what is often missing from our traditional training, right? And so for the first, the full scope reproductive health education and training, we want fellows to understand themselves as reproductive healthcare providers, not only birth attendants, right?
yes.
And really our education really does focus on that, right? And so that includes, prenatal care, birth care, but also gynecology, contraception, primary care, gender affirming care, options counseling, and abortion related care. Um, so yeah, that was really important to me. And in everything I talk about and everything that people will tell you about me, I always talk about as being comprehensive reproductive healthcare providers, right? I think that's a really important distinction to make, because a lot of times people just think about us as birth attendants and
Right.
catching babies, and so I tell people that we as midwives can do far more than that. And then I guess second is Black feminist thought, which really gives fellows a framework for understanding power and intersectionality and the lived experiences of marginalized communities. And then I think the third is leadership and mentorship. And that's because we are not simply training people to fill jobs, right?
That's right.
We want Black midwives and midwives, period, really to lead practices, organizations, educational programs, policy work, and really movements, because midwifery is activism, right?
Yes.
And the fourth is the neonatal and postnatal care. And the reason I pulled that one out was because I feel like in the way we're trained in a very highly medicalized environment, we had very little interaction, with the neonatal care and postnatal care, right? And so, as midwives, we can care for babies up to 28 days, right? And so also in Tennessee, what I was seeing, where Black infant mortality really is a profound concern. We wanted fellows to develop real depth in newborn care, lactation, postpartum mental health, and really family-centered care. because that is really what our community was showing us that it needed. And then fifth was community and patient-centered care. That was important to me because I wanted us to learn to build trust and practice true shared decision making and respect community knowledge, right? Community knowledge is really important, and understand that healthcare systems, uh, you know, or really the healthcare does not begin or end inside the clinic. And so for me, these pillars are interconnected, and that's really important. And you really can't separate clinical competence from power and community and leadership or justice.
Well, and the other thing I thought about when I first read that neonatal and postnatal care, and before I kept going on in the article, is just the fact not only newborn mortality, but also maternal mortality and the higher rate among Black women, and that much of it's preventable, and that much of it occurs after the time of birth. So
Absolutely.
yeah, so it sounds like a really important piece that you've added. So tell us a little bit about the day to day, the nitty gritty. I think you said it was a year program. Are people sometimes in a classroom? Are they in clinical facilities all the time? Are they having discussions? What does it look like to be there in
Yeah.
Memphis?
Yeah, we definitely, when I first started it, Melissa, I like to read. I'm a reader, and I think you can see like all my books
I
back
noticed that
here,
pile
right?
of books.
Yeah, yeah, yeah. That's just a few of them. I have a whole bookshelf over there, and I love to read. And so when I started it, I ordered like a library full of books for the clinic, and I'm like, oh, I had created this syllabus, and we're going to read these books and these articles and all these things. And they were like, "Are you crazy? We're not reading all those books." uh, I was like, "Wait, what? You don't want to read?" I mean, I had really picked some really great books. I had a really great reading list, and I didn't make it just for like the fellows, but really anybody in the building that wanted to join and read these books with us, right? Um, But yeah, they told me, "No, no, we're not reading all those books." And so, so then I had to pivot and, then find maybe articles or podcasts or different things to share, right? But, the day-to-day looks like, definitely clinical work, but also, uh, supporting them in what it is that they feel they need, right? So we definitely, there's certain areas that they feel stronger in, that they want to feel stronger in, wanting to know what they want to learn more of, um, giving them opportunities to go to conferences, and also taking field trips to visit other spaces. Because for me, part of what I was able to do here at Choices was to be innovative, right? I was given a blank canvas to kind of do whatever it was that I wanted to do, and really to reimagine how care could be. So one of those things that was really instrumental for me was being able to visit other spaces and to see what others were already doing, to see what worked, and really not trying to reinvent the wheel. So we definitely take field trips and visit other spaces, and not necessarily just other clinics, and they don't have to be clinicians. They can be community, activists, or, we've gone down to Montgomery, Alabama to visit Michelle Browder, and, gone to other spaces, gone to Washington, D.C. to visit Aza Nadiri at Mama Toto's Village, and just anywhere that, they say they want to go, or even have people come in. We have people come in for trainings. We had Nail Thorpe here
Yeah.
recently to do suturing training. We've had Tina Brangma come in to do herbal training. Uh, you know, we have other providers who are not, midwives come in to do trainings for us. Just so that we can expand our knowledge and really think about how we provide care differently, and honestly how we partner with other modalities, right? So those are really important parts of it as well. And then I encourage them to write. Uh, Sometimes they will, and sometimes they won't, and sometimes they want outline and whatever. But we do encourage them to write and to share their thoughts, and recognizing that that's an important part of what it is we do.
Yeah. Well, you've sought funding from a number of sources in order to
Oh yeah,
support the
absolutely.
program. Can you tell us a little
Yeah.
bit about how you did that? Because everybody always wants to know how to raise
Oh,
funds for a
everybody.
project,
Yeah,
and this is a
yeah.
special one.
Yeah, everyone always wants to know that, how do you fund something like this, right? Um, so we definitely sought philanthropic support, and we were fortunate to receive funding from organizations like Kellogg Foundation and Skyline, and even have received some funds from Robert Wood Johnson and other foundations really that are committed to, health equity. But I think the important lesson is that we did not pitch this simply as a training program. We did frame it as workforce development
Ah,
and maternal health equity and reproductive justice and community infrastructure. So, and that was important. And then we built a real budget. If we say financial barriers prevent Black people from encountering and remaining in midwifery, then we cannot design a fellowship. Doesn't require someone to get compensated, right? We don't want people to work for free or live on a stipend that doesn't support them. So that was really important to us as well. So the funding really does support, competitive salary, relocation fees and mentorship and travel and conferences and the broader learning infrastructure. That mentorship piece is important, and they also have a mentor that is not part of Choices, right? And that Tia Thompson is one of the mentors, and she's out in California. And when we talk about funding and sustainability, I always want to be transparent that sustainability is an ongoing challenge. Philanthropy can help demonstrate what is possible, but ultimately we need healthcare systems and educational institutions and really policymakers to invest in this kind of workforce development.
yeah. I will say, I know exactly what you mean when you talked about you wanted to really fund it and make a real actual budget that worked. And so I thought about that reading the article because when I saw that you provided not only a salary and other expenses, but to help people move there because it's in
Yeah,
Memphis, to
yeah,
me, that was a real demonstration of that, the real cost of
yeah.
somebody to come to it and be successful.
Right. Yeah. I mean, we can't ask people to pick up and uproot and not give them the things that they need. And, you know, uh, but they also are eligible for benefits, right? So, we have health insurance and 401k and all of those things. And all of those things are important, right? And so, yeah, so we provide all of those things.
So, backtracking just a tad, you talked about the field trips in different places you go. And in the article, you talk about policy work in particular. And as midwives, that's a big important piece of what we need to keep doing to keep growing and be better able to provide the kind of care you're talking about. So, can you
Yeah.
just share a couple of examples of policy specific activities you've done with the fellows?
Yeah. Yeah, of course, policy engagement is important because we want fellows and midwives to understand that what happens in the exam room is shaped by decisions made, from far outside of it, right? So, one obvious example has been our abortion policies. Our first cohort began in the summer of 2022,
Oh,
just weeks later, Dobbs' decision was overturned, and then the Tennessee, had a total ban that took effect. So our fellows were not studying policy as an abstract concept. They were watching policy immediately change what care patients could receive and what clinical training was available to them. And fellows have an opportunity to engage in advocacy around access to reproductive health and midwifery care, and attend conferences where policy is being shaped and understand how to communicate with stakeholders about barriers facing patients in our communities. And we are very engaged in policy. We want them to recognize that policy and advocacy is not separate from midwifery practice. Um, if a law determines whether, my patient can access abortion care, or whether, Medicaid reimburses our services, whether a birth center can remain open, or whether, a midwife can practice to the full extent of their training. These are all clinical issues. And so for us, we do have, we even have our legislators come to the clinic, and we talk to them about policies that affect our patients. And we actually had one in last week. And we do a presentation for them around our patients, what their needs are, and how uh, the policies that are happening here in Tennessee are shaping their outcomes. So, policy is not adjacent to clinical care. Policy determines what clinical care is possible. So that is an important part of what it is that we do.
Yeah. Yeah. It's kind of like it lets you open or shut the door
Yeah,
in,
absolutely.
in some ways. Though your article was about the development of the fellowship and what's going on, not a research project per se, I'm sure the fellows have given you feedback about how it's going for them. And I wonder if you just share a little bit about the experiences they've shared with you so far.
Yeah, it's ever evolving, right? Because nothing is perfect, right? And it is our intention for them to have good experiences. And so and have experiences that are going to help them grow. So, really the reflections from fellows have, really been incredibly important, because, like I said, we evolve, and that evolution really is based on feedback. So, I think one of the clearest themes that has come up for us is confidence. Fellows describe becoming more confident in labor management, as particularly in community birth settings, and really more confident in themselves as healthcare providers. They've talked to us about how a more holistic model has helped them become stronger educators and build deeper relationships and build better rapport with their patients. And they've described, growing into clinical autonomy,
Uh,
not just knowing what to do, but trusting themselves to assess, decide, and act, right? I think that distinction matters because graduation and certification, establish, that someone has met, certain standards, right, for entry into practice. But that transition into actually inhibiting the role of a midwife, or inhabiting the role, of a midwife, is really a developmental process. So, yeah, I think that, to me, one of the most meaningful things for me has been watching them to begin, to see them develop differently. Many of them arrive as new grads and be like, am I ready? And over time, they become, these amazing clinicians, and just amazing community advocates as well. And I think that that's what's really important, right? Like I said, nothing is perfect, but we're ever evolving and ever growing. And one of the things I think that's really amazing about being able to do this type of work is being able to pivot, right? So if something else is needed, being able to provide that. But I think that seeing them grow in that confidence, especially in out of hospital birth, uh, and sexual, and become sexual and reproductive healthcare experts, is really great.
Yeah, that's great. So with all of this and all you've been doing and all your pivots, do you have some I don't know if recommendations is the word, but just some thoughts or suggestions you'd share with our colleagues that are being faculty in basic midwifery programs, like before these fellows come to you, some suggestions for them?
Mm, yeah, I think that um, my first recommendation is to stop assuming that graduation means development
Oh,
is complete,
mhm.
right? New midwives need, transition support, structured transition support. Um, I think that we need to examine where and how our students are trained. Um, yeah, I think that if the majority of our clinical education continues to occur, in highly medicalized settings, uh, we really shouldn't be surprised when graduates have difficulty trusting, physiology or transition into community practices. I think also we need to understand that mentorship matters, representation matters. Black learners should not have to navigate the profession without access to Black midwives and other mentors who really understand the racialized dimensions of training and practice, right? And we need to teach the full reproductive health continuum.
Yeah.
Midwives need meaningful education and contraception, abortion, miscarriage management, primary care, sexual health, gender affirming care, and policy, not only prenatal care and birth. And I guess finally, I guess I would say faculty and preceptors need to ask whether we are training students to reproduce the systems we inherited or giving them the tools to transform those systems, right?
Ooh.
Um, yeah, we
Yeah.
should not, yeah, we should really be helping them to think about the systems in a very different way and how they can be transformative.
That's powerful. I agree with you 100%. That's really important. So you started to get into this a little bit by mentioning preceptors, but any thoughts about just ordinary clinicians, our colleagues that are just out there in whatever regular everyday practices based on what you've been doing?
Mm, Say it again. You went out a little bit,
Yeah,
Rosa.
yeah, just any thoughts about how parts of your work can transfer just to regular midwives out there in regular clinical
Yeah,
practice, whatever that means.
yeah. Uh, I don't know. I think that my work is what midwifery is. I
It
think this is
mhm,
what we're supposed to be doing, right? Like,
mhm,
uh, you know, um, I think that the translation is like in recognizing, like I said, especially new midwives need mentorship. We all can do that, right?
mhm, yep,
I think that there's some things that are just should be synonymous with the work that we're doing, right? Like I said, I always emphasize that we are reproductive healthcare providers. We're educators, we're advocates, leaders, and members of our community, right? So all of us can do that. All of us can translate that into our work. I think that mm, I think that we have a responsibility to that we can make room for others, right? um, and particularly for people who have historically been excluded from the profession, right? I think that's an important part of the work that we can do. Mm, I don't know. I think that some of the things that we can incorporate into what we do is definitely looking at reproductive justice as a framework that leads and guides us. And when I think about reproductive justice, I think about I look beyond patients at and individual encounters, and really look at the barriers affecting patients. Really asking what structures are producing the barriers. Is it transportation? Is it insurance? Is it racism? Is it clinical design? Is it language access? And um, so I think as midwives, we have always had the potential to connect um, intimate care with social change, right? And I
yeah,
think we need that part of our profession now more than ever.
yeah, yeah. I agree with you. Now, one last question before I just ask you to sum up. So I know you're working on some research, and I know you're always collecting data there in Tennessee
Yeah.
and Carbondale. So
Yeah.
what kind of research do you think is needed to kind of bring forward your model so others can
Yeah.
use it and take it forward?
Hmm. Yeah. I think we need several levels of research, right?
Yeah, always.
Right. I think we need longitudinal workforce research. We need to understand, are midwives remaining in midwifery? Do they remain in community-based practice? Do mentorship and structured transition programs, affect burnout, retention, leadership development, and professional satisfaction? I think that we need to examine clinical outcomes, not only birth outcomes, but access to full spectrum reproductive health care, um, postpartum outcomes, patient reported experiences. I think those are really important. I think we need research on, and this is something that, that I do ask our patients about. Like you said, we collect a lot of data. I like data, Melissa. And, we actually have a research coordinator, and she creates me these beautiful spreadsheets and a beautiful dashboard I look at because I ask her about a lot of information. But I think we need research on trust and care experiences, right? Does culturally congruent care change whether patients feel, heard, respected, safe, and able to really participate in decision making and participate in their care, right? Um, and I guess ultimately, I would love to see a multi-site research, um, because the question is not whether every community should replicate choices exactly, but I do think that um, we need to examine new models of care, right? And I think choices is a good example of a different model of care. Um, and while people may not be able to replicate us completely, I think there are elements of this model that are transferable and what communities need. Yeah.
Okay, well, that's great. So, as we wrap up, if you were to just summarize, what's most on your mind today for our listeners in a sentence or two, what would that be?
Mm, what's most on my mind? I think that if we are serious about maternal health equity, we cannot simply recruit, more Black midwives into systems that were never designed for them to thrive. Um, we have to build and fund new models of education and mentorship and community-based care that allow Black midwives to enter the profession and stay in it, lead in it, and transform it.
Yeah. Okay. Thank you so much, Dr. Grayson, for engaging in this conversation today. It's been a real pleasure.
Thanks for having me.
So I appreciate your participating in Speaking of Midwives today with the Journal of Midwifery and Women's Health. And to our listeners, thank you. And please join us next time. Thank you for joining us on Speaking of Midwives, brought to you by the American College of Nurse Midwives and the Journal of Midwifery and Women's Health. If you were inspired by today's conversation, connect with us through ACNM's channels. The Journal of Midwifery and Women's Health is at jmwh.org, your resource for cutting-edge midwifery and women's health research. See you next time.